tell the people at your site of care what to do in that really, really narrow window. And getting it wrong is fatal.
So you have a system where you can use telemedicine procedures and inject specialist care anywhere.
And it doesn't work at all, no matter how advanced the technology is, when the trust disintegrates.
The chances still exist for any one of us. Any one of us could have, some sort of a heart attack or a cardiac condition. We could have a stroke, any number of things. That's likely at any time.
On this program, we focus on elevating and taking control of your health so you can live your healthiest life possible. Be sure to stick around for our segment, 1 Minute for 1%, where we provide actionable tips in just 1 minute to help you improve your health by 1%. Welcome on in to the Health Elevated podcast. I'm your host, Dr. Fowers, and I'm joined by Dr. David Hedges and special guest Joe Van Duren. It is known that emergencies in healthcare require precise and quick and accurate care. Fortunately, there are new and cutting-edge technologies that are coming out nearly every day to help optimize this care and make it the best for individuals. But can we trust this? What's going on with it? Joe Van Duren is a statistician who recently published some work on the cutting edge of this type of technology. And Joe, what are your thoughts on the cutting edge of emergency room care?
I feel pretty strongly about this. I've had a few people in my family who have had need for emergency services, particularly in the stroke realm. And the paper that I was able to work on with some of the neurologists here at Intermountain was designed to help us understand the need of our wider community, our population that Intermountain serves, to see what the rate of stroke in our community is, and how we can address that most effectively and timely. That's kind of the thing about stroke that's different from maybe other health needs, is that there's such a narrow window for optimal outcomes. If you go past 3 hours even from the onset of stroke symptoms, the care that's available is less effective as that time progresses. And so it's important to have the technology in place and the services in place to get people, even in rural communities, from recognition to emergency services to competent professional care to administer the life-saving medications that exist in that window that's so narrow, in order to make it so that they can go back home, and that if there is some damage, that it can be reversible as best as possible based on that window.
So Joe, I grew up in a more rural area, and then I spent a portion of my professional career working in a health system that serviced even more rural areas, very, very remote areas where care could be hours away. And I think that access to care, particularly within those rural settings, is challenging. And in many cases, like if you've got a 3-hour window to seek care and you live 2.5 hours away from your nearest center, that's a huge challenge. But your paper really gets at that, really, trying to decrease that time to care. Can you tell us more about kind of like what that paper, what that process was setting up? Because I think it's one of the most remarkable things that I've seen in acute care services for several years.
Yeah. So the main aim of the paper is to determine staffing needs of how many neurologists do we need to have at any given hour time frame of the day to address the needs. And one interesting thing that we noticed in this research is that depending on the hour of the day, there's more or less probability of somebody coming in for emergency care of a stroke. We noticed that during the nighttime hours, for example, the need tapers off, and then as people start waking up, it slopes up, and then eventually it peaks around dinner time, actually, which is kind of interesting. And so, it's expensive to have too many neurologists sitting around waiting for somebody to have a stroke in the Intermountain West, right? But if you have too few, and somebody, like, I live in Cedar City, right? If somebody has a stroke in Cedar City, and then a few people have a stroke in northern Utah, all at the same time, and there's this small group of professionals that can address that. Even though there's these rooms in local hospitals that are near enough to the people to get that timely care, if they get to that room and they can't get online with a neurologist because they're tied up with other calls of stroke care that are happening concurrently, then that's another delay, right, in the service. And so what the paper aimed at was trying to get a feel for the probability of a certain threshold of strokes happening, and calls, not really strokes happening, but the call for the stroke coming in during given hours, and having that staffing right there ready to go, jump on the call and assess the issue and administer the drug. Because you can't just, TPA, that's the type of drug that's typically used for treating the acute ischemic strokes. If they you have a clot in your brain, you need to decide whether to go in and remove it mechanically or to administer this drug. If you get it wrong, and I've done some other work with some other neurologists too, determining like when is TPA optimal. If you administer it to the wrong person, for instance, if somebody's on aspirin and blood thinner, and then they get this other medication that kind of compounds that, then now you're looking at a brain bleed or something even also equally deadly. And so it's really, you have to have that professional right there in the moment to assess the need and be able to tell the people at your site of care what to do in that really, really narrow window. And getting it wrong is fatal, or impairment for life to some degree that is irreversible.
So Joe, I live in an area. There's a hospital about a half an hour away. It's not a major medical center. It's not a quaternary medical center. It's not even a tertiary medical center. It's kind of one step above just a regional facility. And I don't know how many neurologists are on staff, but I'm going to guess that it's not very many. And it's probably not feasible to always have one of those neurologists on staff ready to go with this. So how can your staffing paradigm be scaled to more remote areas, more remote hospitals, where they may not have those resources to have, be able to say, okay, we need 2 neurologists this time of day, we need 1 neurologist this time of day, if there are only 1 or 2 neurologists at that hospital, or maybe even, with more of the more critical access hospitals, there may be no neurologists at that facility. So how can we get that level of care in a distributed network?
Yeah, it's a great question, and it's something that we certainly have grappled with for as long as we've needed stroke care, right? And the amazing thing is, one of the hospital where the neurologists are actually physically present it's called the virtual hospital. So patients don't actually go into it, but the telestroke enabled units that have the screens and the monitors and everything right there. So it's as if that neurologist was present in your rural community. That's ready to go. And that doesn't require a neurologist present in that site of care where the patient is. It just requires doctors and nurses that are trained to follow the protocols that the neurologist dictates.
So you have a system where you can use telemedicine procedures and inject specialist care anywhere across the catchment region or regional network through the technology and through these connections. Is that accurate to say?
Yeah, and it's incredible, right? You don't
That's awesome.
need a ton of neurologists in every single site of care in the entire world to treat strokes. You just need some trained ones in a hub, centralized, that then can have the feelers out to the entire community that's being served. And then you just need less trained and not as expensive people available at the site of care that can follow the instructions. And I think we'll see it more and more common as we go forward, and even to the point where, I don't know, I'm just daydreaming at this point, but anything's possible, right? Imagine that you're in rural America and you have a stroke, and maybe you even have a device that detects it so that your loved one doesn't need to, or it can flag your loved one, give a little alarm like, hey, something might be happening. And then all of a sudden, the whole process is already underway through technology before we even have all the full recognition of what's going on. And then an ambulance or maybe that site of care even comes to the home. Right now it's in the hospital, right? You have to have a telestroke enabled unit. But who's to say that in the future we won't even just have that chain of events happen even faster? The site of care comes to the home, and then that neurologist is online with a paramedic even, and that paramedic's trained to administer the TPA or I don't know. It's amazing what could happen. We couldn't have even imagined what we have today 10 years ago. So
that's true. So you're talking about a lot of things that I would consider, and I think a lot of people would consider as cutting edge. You're saying virtual care, telecare, right? Statistics, numbers to calculate when people need to be on staff and whatnot. And a lot of that has to do with being optimal on the provider side. So when it comes to the people who are having strokes, who need the care, I think a couple things come to mind. So with this kind of new and exciting technology, how much can people actually trust this to work? Like, is it going to fail when they need it the most? Like, can we actually trust it? And what can, like, people do, the individuals who need the care on their side to optimally get the care? Because, again, I think we're talking a lot about how the hospital and the system is trying to be as optimal as possible. But as an individual, how can I be more optimal to take advantage of this technology? And also, can I even trust it? How can I know that I trust that this is going to be something good for me? I'd love to hear both of your thoughts, David and Joe.
Do you want to go first, David?
You go first. You're the expert.
Oh, okay. Well, this is kind of near and dear to me because, my father actually, he passed away from diabetes, which is kind of unusual today. There's a lot of care for diabetes, and he passed away somewhat young from diabetes just a few years ago. And one of the things that I think led to that series of events was some misunderstanding about care and what's available and what doctors are capable of, and just the trust that is kind of foundational to optimal care and outcomes. And so, as I was raised somewhat in that world of maybe a little bit more distrust of doctors and care and things. And then I decided to go into the profession of studying medicine and started to believe more in people. I think it's something that is foundational to everything that happens in the healthcare system, is that patients have to be able to trust people to treat them, to provide the best outcomes, to care about them to the degree that they put their best foot forward. And I don't know, it's an interesting thing. And we get. I also support the musculoskeletal clinical program at Intermountain, and there's a lot of discussion about robotics and things like that, trying to remove that person interaction so that it's foolproof and fail-safe and all that. But even with those tools, which are amazing, and what we're talking about today, the telestroke technology and everything, it's amazing, but still foundational to it working is a trust relationship between patients and providers. And there will always be that dynamic. No matter how advanced the technology becomes, somebody's always at the wheel, and somebody always has to be trusted to save lives and to do no harm. That's one of the things we talk about in the medical world all the time. And community members, patients, we have to trust that. And so how do we develop that bridge of trust? I think educating people about what's available and what it means, and that it's not just, as we get more advanced in technology, we make clear that it's not the technology that's calling the shots. It's the technology that's a tool that's aiding trained professionals to provide optimal care to needing patients and family members and loved ones, community members. As we develop that understanding and trust, all of this works 10 times better. And it doesn't work at all, no matter how advanced the technology is, when the trust disintegrates. And I think we saw a little bit of that during COVID too, of that trust paradigm. And it was tense. You remember that relationship was tense. And the more that, maybe third parties, maybe government influences or other things like that, or media influence that relationship, it made it more tense. And so we need to be careful about misinformation that may come from those third-party sources to preserve that relationship that has to foundationally exist between the patient and the provider.
Interesting. So, Joe, I've put a lot of thought into this concept of trust, and I don't have an answer, but I have some thoughts. And it seems to me that as humans, I don't know if it's human nature or I don't know if it's just our cultural inclination, but we tend to trust and believe sensational stories, sensational one-off stories. We love rumors and emotion. That's what we trust. And social media preys on this. Sensational news outlets prey on this, and they capture people's trust, and people are influenced by these sensational stories more than we're influenced by aggregations and numbers. And I think that it's fair to point out that these protocols, this wasn't just some rogue neurologist who went off and stayed up all night and wrote a bunch of hypothetical protocols, but protocols for these type of things were developed by reviewing massive amounts of data across huge populations involving thousands and probably tens of thousands of patients to understand how to optimize outcomes at an individual level through studying trends across enormous populations. So a lot of work goes into this on the back end, but then culturally or human nature, we choose to not accept that as much as we accept just my nephew's spouse's aunt saw this happen.
Anecdote.
I'm gonna trust that over what was vetted and validated across thousands of people. For whatever reason, we tend to do that. I think the first step to trust, in my mind, is acknowledging that we tend to trust these sensational emotional outlets with emotional stories. For whatever reason, we tend to do that. And after we acknowledge that, then we can recognize that and then ask ourselves the hard question, Do I want to trust one random story that may or may not be true? Or do I want to trust people who have invested considerable time and effort into determining the truth of a matter and are
Yeah.
really trying to optimize things? For whatever reason, as a culture, we choose to go with the emotional story
Yeah.
that may or may not be true. And I think we really saw that during COVID. Our emotions were high, things were tense, trust was broken. And now I think we need to heal from that. And I think step one is recognizing those human tendencies and trying to move forward and recognize that these protocols exist, and they exist to help people be better, to help people have better outcomes.
And with that, we got to get to our 1 minute for 1%. So we're talking a lot about telehealth, telestroke technology, and Joe has a 1 minute for 1% that will help you get 1% better in your health. So let's get it.
So, not to reinvent the wheel, right? There are things that we can remember from a patient perspective and from a family member's perspective. There are mnemonics that exist and things that can help us remember what to look for so that we can initiate that cycle of events that get people into this care pathway to get the triage that they need immediately. And it starts with us, right? It starts with the family members and ourselves. So FAST, that's the mnemonic, FAST, to help people quickly recognize and identify signs and symptoms of stroke. So face is the F. If you see drooping on one side of the face, an inability to smile, or a drooping mouth or eyes, that's that, and it's usually just one side of the face. That's a sign that there's oxygen's not getting to a certain part of the brain, and those are the first symptoms that you'll start seeing. Another one, arm, a weakness or numbness in an arm or leg, or an inability to lift both arms. And so you can have them, try to lift, and if one starts to kind of sag down, that's a telltale sign. Speech, slurred or garbled speech, an inability to speak or difficulty understanding what others say. At that point, time to call an emergency service. 911. They are trained. They even have technology services there, AI algorithms that can help the rapid pace of determining what somebody needs and get that care out there immediately. Other quick things to look for if you suspect stroke: loss of balance, difficulty walking, difficulty seeing out of one or both eyes, sudden confusion, fainting, a seizure, or sudden severe headache. Don't hesitate to call. It's better to err on the side of safety than to delay the life-saving care that exists.
Rylan, what I like about this is a lot of our conversations revolve around, managing your health to the point where you can decrease the chances of stroke, decrease the chances of emergency services. But that's all we're doing, is decreasing those chances. The chances still exist for any one of us. Any one of us could have, some sort of a heart attack or a cardiac condition. We could have a stroke, any number of things. That's likely at any time. And I am extremely critical of the American healthcare system for a lot of reasons, and we could go into that, but we're not going to do that right now. But one thing that the American healthcare system absolutely knocks out of the park is emergency services. We have dedicated tons of money to emergency services, and from the numbers that I've seen, the American emergency services by far lead the world. We are the best when it comes to emergency services. So I think it's important to really recognize that although we try to minimize chances through healthy living, minimize chances of these things from happening, it still is critically important to recognize when we do need emergency services, just like Joe just described, through that fast mechanism for stroke or any other things for when we require or when we're likely to be, facing a heart attack or any of these things. And to know where to go and what to do. That becomes down to a responsible consumer of healthcare, and a truly democratic approach to managed healthcare is knowing and recognizing what those symptoms are so that we can, when the needs are there, we don't just die, but we can go in and avail ourselves of truly cutting edge, impressive technologies like Joe described earlier. And I think that is, it's a good reminder for me, because I get so focused on, well, I just need to do my healthy living and then I don't have to worry about these things, but that's not true.
Right.
I need to do my healthy living. That's my responsibility, but it's equally my responsibility to know when I need acute care services and take advantage of those incredible professionals who develop very impressive systems to maximize outcome potential.
And it gives me so much more trust as a consumer, knowing that intelligent people like Joe are working on these problems to try and optimize the care so that we're all getting the best care possible when we need it in emergencies. Thank you for listening to this episode of the Health Elevated podcast. If you liked what you heard, please consider sharing it with your family and friends, or giving us a like or review. If you have any topics that you're interested in having us discuss, or you potentially want to be a guest on the program, please email us at healthelevatedpodcast@selecthealth.org. That's healthelevatedpodcast@selecthealth.org. Otherwise, we'll catch you in the next episode.